All right, welcome back this morning. Our next presentation is virtual for everybody, not just for some people. We have Dr. Brian Beldowizc is going to present to us. So in here is the hemorrhage control, if that's the class before. The other session is EV right now. So this is what we have here. So Dr. Beldowizc, you there? You hear us okay?
Yep, we're all good. You guys hear me?
Yes, really well.
All right, so the point of this is to go beyond the basics of hemorrhage control. So forgive me, it's kind of a little hard sometimes to fine tune things, but I know you guys know, application of tourniquets and bandages and things like that. But I think getting behind to some of the other things that can contribute to ongoing hemorrhage and trauma, just to give you a little bit of understanding of slight little tweaks and things that you could do or pay attention to that you might not otherwise necessarily recognize or think of. I always start with these, EMS presentations in particular to say, I mean, I work very closely with a lot of the county EMS officials and things like that. And, I know how much effort goes into your protocols and things. And so I would never advise anyone to contradict their standard protocols for different things. But this is more just to try to give you an understanding of the physiology behind kind of what's going on with traumatic hemorrhage and why it can become so problematic, and why dressings may work in some patients and not in others, and why different wounds, different types of hemorrhages can actually become life-threatening. So really our objectives is really to start with from a simple format. When we talk about hemorrhage in hospital, we talk about surgical versus non-surgical hemorrhage, and that's easy to kind of distinguish in that surgical hemorrhage means that there is a hole in a blood vessel somewhere, and that hole is pouring out blood. And the treatment for that is surgery, right? It's fixing that hole, it's plugging that hole, it's sewing it shut, doing something, whether it's with a dressing, a suture, or a tourniquet. It's stopping blood from escaping a hole in a blood vessel. But there's lots of things that can cause non-surgical hemorrhage and trauma, and those are things you can't fix with sutures or dressings. And in fact, those are times when we find ourselves in the OR and people are bleeding from non-surgical hemorrhage. That's an indicator for us that we have to get out of the OR and get somewhere where we can better fix the other things that are contributing to hemorrhage. So we'll talk about those. Really, it comes down to what's called the lethal triad. I'm sure most of you have probably heard that referenced before, so we'll go over some of the basics of that. And then some of the ways to try to intervene, interdict, or even prevent that lethal triad from developing. There's strategies that are called either hemostatic resuscitation or something in the military that we started called advanced resuscitative care. And again, those are really targeting trying to target all of the different potential etiologies of hemorrhage, both surgical and non-surgical. So if we start with just talking about the lethal triad, this is actually the drawing from the the Journal of Trauma article from 1982. And I absolutely love it because this is one of the most groundbreaking, physiologic phenomenon in traumatic hemorrhage. And basically, it was first described by some guy with colored pencils and a typewriter who just put this thing together. So, truly a remarkable advancement in our understanding of hemorrhage came along in 1982. And so basically, the components are, coagulopathy, acidosis, and hypothermia. And so if a patient is acidotic, that makes them more coagulopathic, which will then, worsen hemorrhage. Worsen hemorrhage will then make them more hypothermic, which will, a combination will then make them more acidotic, which will make them more coagulopathic. And so this cycle starts where one keeps contributing to the other, and it can be very hard to stop bleeding. You can be the best surgeon in the world and place the best stitches and apply the best dressings, but if you have an acidotic, hypothermic, and coagulopathic patient, that patient is going to continue to bleed. And that's that idea behind non-surgical hemorrhage that says, it's no longer a hole in a blood vessel. This is raw surfaces that are oozing blood. This is the liver surface, the subcutaneous tissue, muscle surfaces that normally would not be bleeding are now actively bleeding just because the patient has lost all the ability to clot. So this is basically their description and their conclusion of their study. was that coagulopathy, hypothermia, and acidosis are complicating factors which demand as much attention of the surgeon as the initial resuscitation and the operative control. So again, so often it's actually the non-operative or the non-surgical hemorrhage that is the truly life-threatening component of hemorrhage for a lot of our trauma patients. What this study in 1982 had found was they found that patients, that had major vascular injuries, they still 90% of them bled to death. But of those that died, of those that died, 90% of them bled to death after the blood vessel that was bleeding had been repaired. And so that was that idea that, hey, even like there is something else going on here beyond just blood leaking out of holes in blood vessels. So we start with talking with an understanding of acidosis, and I think one of the things that I think would be important for you guys to understand, in a way to try to improve your own ability to control non-surgical hemorrhage, is this idea of acidosis. So when somebody sustains a traumatic injury, their body is naturally going to release adrenaline or epinephrine, right? Those are the same things, and that causes a significant amount of glucose breakdown or for the production of energy as part of that fight or flight response. So when you're breaking down glucose, you're generating a lot of carbon dioxide. And then when you overwhelm your cell's ability to produce energy from through aerobic metabolism of glucose, it starts metabolizing glucose by the anaerobic pathway, which generates lactic acid. And so the way your body normally neutralizes acid, or this H positive on the far left, is that it combines that acid with bicarb, right, HCO3. And when you take those two things and put them together, the body can then break that down into water and carbon dioxide. So what does this have to do with you guys? Basically, there is a risk of exacerbating non-surgical hemorrhage in patients that are hypoventilated. So if carbon dioxide is building up on the right side of this equation, it's going to prevent any bicarb in your system from neutralizing acid. So the only way to neutralize that acid with the bicarb is if you are also blowing off that carbon dioxide. So it's when patients who are in hemorrhagic shock probably need more than one breath every 5 seconds. In general, we will be breathing them in our hospital somewhere between 20 and 24 times a minute. Their tidal volumes may be even a little bit higher. So just something to keep in mind in patients where you're struggling. If you think that they're in hemorrhagic shock and you're having really hard times with their hemodynamics, hyperventilation may help you neutralize some of the acidosis that could be contributing to that. So when we talk about hypoventilation, really what we're talking about is minute ventilation. And minute ventilation is basically just a combination of respiratory rate, or RR, times your tidal volume. So if you wanted to improve your minute ventilation or increase your minute ventilation and therefore blow off more CO2, you have to either increase your respiratory rate or increase your tidal volume, or both. Other components of acidosis that we can sometimes exacerbate actually involve the way we resuscitate patients. So when you look at here, this lists kind of most of the things that we might try to resuscitate patients with in a hospital setting, some of which will be also available to you guys. So obviously Linger's lactated ringers and normal saline are things that you guys carry. I don't know if you carry a plasma or what's called a balanced electrolyte solution. And then there is certainly some interest in having you guys doing some pre-hospital blood transfusions that we'll get to in the future, or later on in this presentation. But what's interesting is if you look at the things that we use to resuscitate patients, whether it's in the pre-hospital setting or the hospital setting, so many of these things are profoundly acidotic, right? So normal saline has a pH of 5.5. So if you're giving patients 1, 2, 3 liters of normal saline, there's a significant chance that you are contributing to their acidosis. Same thing. Ringer's lactate has a pH of 6.5, and really what we're shooting for is that pH of 7.4. That's where we know things clotting factors and adrenaline and vasoactive medications and all those sorts of things, we know those are going to function best the closer we can get to a pH of 7.4. And so if the patient himself is generating a lot of acid by producing lactic acid, and we're trying to support their blood pressures with normal saline or even Ringer's lactate, we know those things can actually worsen the acidosis rather than reverse them, especially in the patients that are most that have suffered the greatest blood loss and are under the most stress. So the next component is that coagulopathy. And so there's really 4 different ways that patients can be coagulopathic. We talk about consumptive coagulopathy, which basically means that they have consumed their clotting factors or consumed their platelets. That this is the classic idea is that what's called diffuse intravascular coagulation, or DIC, or that they've got so many sites of hemorrhage that they're really consuming all of their platelets and clotting factors, and therefore there's not enough left available in the bloodstream to continue to clot off other areas of injury. Then there's dilutional, which basically says you may have the right number of clotting factors or platelets, but if you're giving a bunch of fluid or even blood products that do not contain clotting factors and platelets, over time you're going to dilute those things, and so the actual effectiveness of them will be substantially lessened. Then there's functional coagulopathy, and in these patients, they may have the right number of platelets and they may have the right quantity or even concentration of clotting factors, but functionally they're not working. And why would that be? One of them might be because they're on medications that inhibit those things, whether it's anticoagulation medications. Another reason could be that they're acidotic, and that those medicines or that those clotting factors and platelets just simply don't function outside of the normal pH range. It could be that they're coagulopathic. There was a recent study that was just published that shows that, not coagulopathic, but hypothermic, and that hypothermia significantly contributes to platelet dysfunction. So even if you have a normal number of platelets, if you're hypothermic, those platelets simply are not going to be as functional. And then there's this concept of hyperfibrinolysis, which means that your body may be able to form clot normally, but then it is rapidly breaking that clot down, in a maladaptive response. And we'll talk about what the significance of the hyperfibrinolysis is in just a moment. So in the hospital, this is going a little bit beyond whatever you would need to know, but I think it's important because it'll give you an understanding of kind of the things that can contribute. So in a hospital, we will often check a blood test that's called thromboelastography, or ROTEM, TEG or ROTEM. And basically, this is a schematic that shows they put the patient's blood in this little cylinder here, and then they take a needle and they put that needle in that blood, and then they agitate the blood. And what's supposed to happen is that as that blood clots, the needle will meet more and more resistance as the clot gets stronger and stronger. So it will actually generate a graph that we'll look at, and you'll see, in the beginning of this graph on the far left, that is before the clot starts to form. That's where you're accumulating kind of clotting factors at the site of injury. And then the clot will start to form, and this graph is showing the resistance of the needle against that clot. And so the wider that graph, the more resistance that needle is encountering, and therefore the stronger the clot. And then we monitor this over time, and it'll tell us different things about whether the problem is in clot formation, like the initiation of the clotting cascade, whether it's in clot propagation, meaning the clot starts to form, but it forms very, very slowly, whether it's in clot strength, which means that the clot is forming okay, but when it reaches its maximum strength, that it's still fairly weak. And then there's that clot lysis, or hyperfibrinolysis, that I was describing, where the clot may form normally, but your body is having a maladaptive response and is breaking down that clot very, very rapidly, essentially causing rebleeding. And this is an actual example of the kind of graph that we will get and we will see, and this gets generated real time on our computer screens in the hospital. So again, you'll see a lead time that shows this little needle on the left where the clotting factors are accumulating. So that's clot initiation. Then you'll see how rapidly it forms, how what it reaches when its maximum, when it reaches its maximum strength. And then you see that that strength persists over time, which shows you that there's not significant fibrinolysis or clot breakdown that is exacerbating bleeding. So again, we'll talk about when we think about it in terms of formation, propagation, strength, and lysis. And so on the right side of this screen, you guys can see what some of the atypical elastograms would look like. So the very top is a normal elastogram. And then you'll see with platelet inhibition, which is the third one down, is that, you know, the initiation seems good and then the propagation seems good, but its maximum strength, that resistance is much narrower or much less strong than it is on that normal graph on the very top. And right below that, on the fourth one down, you see that fibrinolysis, where you get, you know, the initiation is normal, propagation is normal, and then even that maximum strength is about the same as that normal one, but then rapidly your body starts to break it down, and that resistance against that needle dissipates, and you see that the graph starts to narrow again, and that's that hyperfibrinolysis. So what is the significance of this? A problem with clot formation, meaning it takes too long to start forming that clot, that usually means that there's insufficient clotting factors. And so we treat that by giving the patient plasma, because plasma has the most concentration of clotting factors. If the problem is clot propagation, meaning that it starts to form the clot you know, at an appropriate time, but then it just forms it very slowly, that's usually an indication that the patient has insufficient fibrinogen, which is one of the clotting factors. And then we treat low fibrinogen with either a medication called fibrinogen concentrate or a blood product called cryoprecipitate, which is also, you know, something that we get from our blood bank. When we talk about maximum clot strength, that's actually a problem with platelets if they have insufficient clot strength. So if we see that like the third one down with platelet blockers, if that amplitude of that resistance is too narrow, that indicates that the platelets are not forming good strong clots, and we therefore need to give more platelets. And then when we talk about clot lysis, meaning that you're forming the clot normally but breaking it down rapidly, that's where we give TXA, right? So it's tranexamic acid or TXA. That treats that fibrinolysis. It means that once your body forms a clot, it's not going to break it down if you inhibit that. So that's really why we're giving TXA you know, pretty regularly. The reality is that if there is not hyperfibrinolysis present, then the TXA doesn't really have any downside effects, right? Like it's only going to act to inhibit fibrinolysis. And so if there's not significant fibrinolysis going, then the TXA is not necessarily detrimental. It's also relatively inexpensive and safe to administer. And so that's why TXA is becoming more and more common in pre-hospital settings. You know, and we're seeing it in a lot of other kind of bleeding as well. So not just traumatic bleeding, but if there's concern for hemorrhagic stroke and brain injury, they're giving it in OB emergencies if there's postpartum hemorrhage, those sorts of things. So anything where you just want to try to inhibit the breakdown of the clot that your body is forming, TXA is a good answer for that. Then we talked about the last part of the lethal triad is hypothermia. And, you know, studies have shown that up to 12.6% of severely injured patients are hypothermic on arrival. And it's not related just to weather factors. You know, winter months are a higher risk factor, but again, these are usually patients if they're severely injured and bleeding. These are patients that are at risk. You know, their body's ability to compensate, you know, and maintain normal, you know, thermoregulation is significantly impaired. So they're counting on you and us to try to maintain that warmth. And so the patients that we come in that are the sickest, I don't know if you've ever been in our OR, we'll turn to the nurse and say, turn the temperature all the way up. And every provider in the room is just sweating bullets because you got to try to warm that patient in a way externally because they cannot thermoregulate internally. Well, you guys have an even harder job because number one, you can't just turn on the thermostat, you know, on the roadside. I don't know how quickly you can heat the back of your rigs, but with the doors constantly opening and closing to load and unload patients, I can't imagine that you can maintain great temperature regulation back there or quickly adjust it. So you're really dependent on that, external blankets or any kind of external warming devices that you can do in those winter months, because again, these patients can't thermoregulate themselves. C-spine immobilization, so you put somebody on a hard board, cold plastic board, and then you put a C-collar on them, so that is a higher risk or increased risk for hypothermia. And then obviously blood pressure. So patients that are not maintaining good blood pressure, those patients are the ones that are having end organ dysfunction, thermoregulatory dysfunction, those sorts of stuff. Those are at risk for being, really the sickest patients. And then patients that are hypothermic on arrival, they tend to require more blood transfusions because they have that functional that functional coagulopathy, so that even if they have platelets and clotting factors, they're not working at peak performance because of the cold, and they're at higher risk for ICU admission. So I'll pause there for a second and just see in the chat or anything. Does anybody have any questions or anything I can clarify further before we move on to kind of the next thing I want to describe, which is, one of the new concept of hemostatic resuscitation. All right, I am not seeing anything in the chat window, but feel free to put that in there if any questions come up as we go. So the next thing again is hemostatic resuscitation. And so basically this was designed to quickly restore end organ perfusion and cellular performance in order to reverse the metabolic disturbances caused by traumatic hemorrhage. So like we said, patients bleeding, when they bleed, they get cold. When they get cold, they get coagulopathic. When they get cold and coagulopathic, they get acidotic. And so this is designed to try to interdict and reverse that that lethal triad we were just talking about. The three main components of this are, one is called permissive hypotension, then there's fluid restriction, and then there's fixed ratio blood product resuscitation. So when we talk about permissive hypotension, the very original descriptions actually targeted resuscitation to a systolic blood pressure of just 70 or a mean arterial pressure of 50. The idea being that if you have surgical bleeding, again, so if you're bleeding from a hole in a blood vessel, if your blood pressure is high, that's a higher pressure, a higher force that's going to lead to increased blood loss. So imagine, a plumbing system, or city plumbing. If there's a hole in a pipe and there's a lot of pressure behind that pipe, a lot more water is going to come out, and you can actually lessen the amount of water that leaks out of the pipe by lowering the pressure in the system. So same idea with surgical bleeding specifically. So most guidelines don't go as aggressive as the original studies, and instead they'll say to target a systolic blood pressure of greater than 100 or greater than 110 if you suspect head injury. We know patients with head injuries, if they become hypotensive, there is a risk for progression of their head injuries. So we always want to maintain a little bit higher of a blood pressure if we suspect there's a head injury, as opposed to being comfortable with a little bit lower of blood pressure, especially in somebody who doesn't have a head injury, somebody who's mentating okay, those sorts of things. In terms of fluid restriction, we used to give liters upon liters of fluid. We would try to resuscitate people with crystalloid back to normal blood pressures, and there are plenty of studies that show that resuscitating to a normal blood pressure is actually detrimental, that those patients do worse than patients that you resuscitate just back to those targets I just described of a systolic of 100 or 110 in a brain injury. And so you really do want to restrict that fluid to really no more than a liter in adults or no more than 20 milliliters per kilogram in pediatrics, because we know that fluid's bad. It's bad because it contributes to the acidosis. It's bad because it dilutes your coagulation factors and platelets, and it makes your tissues swell. So really kind of tolerating lower blood pressures and using less fluid is associated with better outcomes in patients who are bleeding. And then the last component, this is maybe one of the biggest advancements we've made in trauma care in the last 20 years, but anytime there's a big military operation, whether it was Vietnam back in the day or more recently Iraq and Afghanistan, you get a large population of traumatically injured patients that otherwise really don't have other comorbidities, right? That's the advantage of the military, is that these are, unfortunately, the people that are getting injured in these conflicts are people that they don't have heart failure, they don't have vascular disease, they don't have diabetes. They're in the prime of their life, they're, physically active, they're in their 20s to early 30s. And so it really reduces the number of, variables that would influence outcomes to the bare minimum. And so what they found in a military study, looking at patients in Iraq back in 2007, was that patients that received lower ratios of plasma to red blood cells. So this graph on the far left side of the figure, if they received only 1 unit of plasma for every 8 units of packed red blood cells, their mortality rate was 65%, extraordinarily high. Go to the far right side of the graph, and it shows that if you receive 1 unit of plasma for every 1 to 1.5 units of packed cells, so much closer to a 1-to-1 ratio, you could reduce mortality from 65% all the way down to 19%. Absolutely incredible when you think there are not that many interventions that can reduce mortality from 65 to 19%. But transfusing more plasma early, to patients in hemorrhagic shock does just that. So they took this study, and then they said, well, it applies to the military, but does this apply to to the civilian side? And it found the same thing, right? So this study went beyond your 20 to 30-year-old active duty military population and took all patients in hemorrhagic shock. Some of them had heart failure, some of them had diabetes, and that's why your mortality rates in both classes are a little bit higher. But in the ratios of only 1 unit of plasma to 4 units of packed cells, the mortality rate was as high as 87.5%. And by reducing that closer to 1-to-1, meaning 1 unit of plasma for every unit of red blood cells, you can reduce that mortality all the way down to 26%. And that's in the civilian population. So they said, well, if it's that beneficial in patients that are requiring massive transfusions, meaning they're requiring greater than 10 units of blood, is it also beneficial in patients who require less than 10 units of blood? And so that's why the mortality rates in both of these scenarios are lower, because again, these are patients that didn't require 10 units of blood, so just by that very nature were probably less injured. But even still, in these patients that had less blood, we were able to reduce the mortality from 21% to just under 12% just by giving more plasma. Everything else being equal, just giving more plasma lowered the mortality rate by almost half. So they said, well, if plasma is helpful, what about platelets? And so they kind of almost repeated the same study, looking at what about platelet ratio to packed red blood cells. And they found that lower ratios, so that you're giving more platelets to red blood cells. So that would be your low, that would be your higher platelet ratios would have a much higher survival rate as opposed to your lower platelet ratios where patients were dying significantly more. So again, the idea is that we are giving platelets for every 6 units of red cells we're going to give platelets empirically. We're not going to wait for a platelet count to be measured as low. It's part of our resuscitation that after their 6th unit of red cells, they're also going to get platelets. So I'll pause again. Does anybody have any questions about the concept of hemostatic resuscitation? Again, the main components being fluid restriction, permissive hypotension, and then that fixed ratio blood product resuscitation. All right, if not, then we'll talk a little bit about what's called advanced resuscitative care. And so this basically also, is a program that sort of came out of the military based on military evidence. And so what they're showing is that using pre-hospital, administering blood transfusion in patients that need blood, giving it to them in the pre-hospital setting offers a significant mortality benefit rather than waiting until they arrive at the hospital to receive that blood transfusion. Then there's the concept of early hemostasis and different things that can be done in the field to try to achieve hemostasis. And lastly is getting rapid access to damage control surgery. So somebody who can come in and plug holes and fix holes and control that surgical bleeding, so that then we can rapidly shift in our attention and control the non-surgical bleeding. Because again, that's usually the one that patients are gonna, will often die of, is actually that non-surgical bleeding after all of the surgical bleeding has already been controlled. So when we look at early blood transfusion, this was a study done by the military, or looking specifically at military patients. And this is a mortality rate, 24-hour mortality rate is what this graph shows. So the bottom line indicates patients that received blood before arriving at the hospital. So they received blood from their field medic, or they received blood from the transport medic. And you can see when you take those patients and you compare them to patients who had the same injury patterns, same injury severity, but did not receive blood before they arrived at the hospital, the risk of 24-hour mortality was substantially higher in the patients that did not receive blood prior to arriving at the hospital. So again, these patients still received blood, they just received it later. And this clearly shows the sooner the better when it comes to blood products. When we looked at the same patient population and looked out to a 30-day mortality, not just the 24-hour mortality, you found that if you got the patient through that first 24 hours, that mortality benefit persisted. So again, the 30-day mortality rate substantially higher, even if you gave them the same number of blood units, just the fact that they didn't start getting blood until after they arrived at the hospital was associated with a substantially higher risk of dying. So when we talk about early hemostasis, this essentially comes down to the things that you guys do in the field in terms of trying to control surgical bleeding. So, we teach Stop the Bleed, and hopefully all you guys are familiar with it. If not, as a Stop the Bleed program, you certainly know the principles of it. And the first is that you start by applying manual pressure to the area to see if you can control bleeding. And if manual pressure doesn't control it, then you need to start increasing stepwise until you feel like you've got optimal control of that bleeding. So if manual pressure doesn't work, a pressure dressing or wrapping the wound, or packing and wrapping the wound would be the next step. And if that still doesn't work, that's when you're going to apply your tourniquet above the injury, when it comes to extremity injuries, and just cut off all blood flow to that extremity. In terms of other options that you have for early hemostasis in the field, one is a pelvic binder. Again, if the bleeding is in the pelvis from an open pelvic fracture, closing down the volume of that pelvis will help control some of that bleeding, or give it less room to bleed, and hopefully tamponade some of that bleeding. And then there's traction splints. If you've got a patient with a femur fracture, they can lose pretty significant blood from that, especially bilateral femur fractures. And so application of a traction splint actually will decrease the amount of blood that's lost from that fractured bone ends and things like that. So these are all adjuncts that you guys have available to you in the pre-hospital environment that could potentially aid in achievement of early hemostasis. So tourniquets were actually, frowned upon for a period of time in between kind of the Vietnam War and the Korean War, and then now, came back into, a favorable light, kind of again with Iraq and Afghanistan. And the main reason for that was evacuation times. When you're talking about evacuating or medevacing patients in both Korea and Vietnam, those were evacuations that took hours to days. As opposed to in Iraq or Afghanistan, the Secretary of Defense basically stipulated that there should not be a single inch of ground anywhere in either of those countries that was not within 1 hour of a surgical team. And so they distributed the hospitals and the medevac assets accordingly, so that any soldier that got injured would be able to be returned to a hospital within an hour. So a big difference. And so when you're doing it that way, application of a tourniquet and leaving a tourniquet on for an hour is not associated with the side effects of somebody that applied a tourniquet in Vietnam, and then it took 12 or more hours for that patient to get evacuated to, onward to another echelon of care. So, we looked at this in the military and the experience in Iraq and Afghanistan. Prior to 2006, that was when, tourniquets still were not considered beneficial. And we were seeing 23.3 deaths per year from extremity hemorrhage prior to 2006. By the end of 2007, so they rolled out in 2006 and 7 is when they rolled out all of the tourniquets and trained all of the soldiers on them and all of the medical teams. We reduced that from 23.3 deaths per year all the way down to 3.5 deaths per year from extremity hemorrhage. So tourniquets alone reduced the incidence of death from extremity hemorrhage by 85% just from the fielding of tourniquets. Pretty remarkable. And so the other thing that's important, and I think that's very important for you guys to understand, is this idea of the clock is always ticking. And this was a study that was done in Pennsylvania that basically looked at all trauma patients throughout the entire state of Pennsylvania that ended up dying from hemorrhage before getting surgery. And they compared the time of injury to the time of death and tried to determine, at what point did these patients die, so that if we had gotten them to surgery ahead of that, maybe they could have been saved. And so this first graph, and I'll show 3, is total deaths of all traumas in Pennsylvania from hemorrhagic shock. So what it shows here is that by 23 minutes, about 5% of patients who are going to bleed to death are going to bleed to death by 23 minutes. And by 59 minutes, 50% of patients that are going to, that die or that are going to bleed to death. So in all patients, if it takes 1 hour from point of injury to get them to a surgical table, you would have missed out on 50% of patients that were potentially salvageable if it took you 1 hour. If you look at that just in blunt trauma patients, so your vehicular accidents, your falls and things like that, again, this is looking at just patients who died from hemorrhage. If it took about 29 minutes for about 5% of them to die from hemorrhage, and for 50% of them to die, it was about 1 hour and 10 minutes. So again, that's from time of injury to time of death. And if we were able to, sorry, I don't know what happened there. So if we were able to get them to surgery in less than 1 hour and 10 minutes, some of that 50% potentially could have been saved. When it comes to penetrating trauma, the numbers are even more stark. So it's less than with blunt trauma. So again, in just 19 minutes, 5% of patients that are going to bleed to death will bleed to death in the first 19 minutes. So if you're going to try to save that person's life, you need to get them from point of injury to surgery in under 19 minutes. For 50% of those patients, that time is 43 minutes. So if it takes longer than 43 minutes from point of injury to getting to the hospital, you're gonna miss out on 50% of the patients that are going to bleed to death will have bled to death. So that's 50% of potentially salvable patients are no longer salvageable at 43 minutes in penetrating trauma. And so the whole point of this really is to indicate that, like, there are things that you can do in the field. There's simple things that you can do, everything from avoiding hypoventilation, from practicing damage controlled resuscitation with fluid restriction and permissive hypotension. You can apply the best pressure dressings, tourniquets when appropriate, all of those sorts of things. But recognize that while you're doing those things, the clock is still ticking. And so really what it means is that you got to be decisive. You've got to be good. and to be able to get these things done quickly in a way that is not going to significantly slow you from getting from point of injury to that hospital. It's particularly critical in hemorrhaging patients, even more critical in penetrating hemorrhage patients. So always in the back of your mind, you should have that ticking clock of like, for every minute, there's a percentage of patients are going from salvageable to non-salvageable for every minute that's delayed from getting them to surgery. So again, to review, we talked a little bit about the role of breathing and resuscitation in acidosis. So again, the role of breathing and hypoventilation, and the role of resuscitation and giving large volumes of acidotic fluids could contribute to acidosis, which is a significant component of the lethal triad. We talked about the multifaceted nature of coagulopathy, whether it is a consumptive coagulopathy, a functional coagulopathy, or forgive me, or from hyperfibrinolysis. We talked about different patterns that predispose to hypothermia, which is that third component of the lethal triad. We then talked about targets of resuscitation and how, you don't necessarily want to resuscitate patients back to normal blood pressures, and that allowing the blood pressures to run a little low means a little less pressure in the pipe, and therefore less blood loss, less ongoing fluid loss, from that hole in the pipe. We talked about the urgency of blood transfusion, and I got to tell you, I literally just came back from the American College of Surgeons Committee on Trauma meeting. So these are the people that put together ATLS and all those sorts of things you may have heard about. And their next big frontier is honestly working on trying to negotiate and navigate the problem of making blood transfusion available pre-hospital to hemorrhaging patients. I know there's in and around Multnomah County in the Portland metropolitan area, they are already at work on this, and the expectation is that within the next year it will be available to EMS. Right now the model, I think, is that it's going to be in a supervisor's truck and not necessarily in every rig, just because that's a lot of blood products to stash in every single rig. We do know that blood products are already available in life flight, so those patients are getting, pre-hospital blood transfusions. But this, there is a lot of interest in this becoming the next big thing, the next big way to kind of try to interdict and lower mortality from hemorrhage. Then we talked about the urgency of temporary hemostasis and the different adjuncts and skills that you guys possess, in the pre-hospital arena to try to limit that ongoing blood loss. And then lastly, we talked about that urgency of definitive hemostasis, that even though we're giving you all of these tools of things to do, we need to optimize a way that we can do them efficiently, that we're not significantly lengthening the amount of time that it's taking to get from point of injury to the hospital. Because again, those patients that bleed to death, they bleed to death quick. 50% of those patients are going to be dead in an hour. So any significant delays, really can take a patient that might otherwise be salvageable, and essentially prevent them from being saved. So here's just a list of some resources. I'm glad to answer any questions you guys have, whether audio, if you have that capability, or put them in the chat. But I hope this was helpful for you. It wasn't my intention to try to overwhelm you with, it's not the expectation that you guys are going to be able to do on the roadside, the things that we're doing in the hospital, but it's more to just give you an understanding of the different things that contribute to hemorrhagic shock beyond just holes in blood vessels, right? Like holes in blood vessels, is a simplistic approach of hemorrhage. So much more goes into patients dying of hemorrhagic shock. Far more patients die from the non-surgical causes of bleeding than I think die from the surgical causes of bleeding. I know that's true in hospital. Statistically, it may not be true in the pre-hospital setting, but there are still some things that you can do that help set us up for success by kind of preventing or mitigating some of those, things that will exacerbate non-surgical hemorrhage. So that was my goal, is just to give you some strategies and ideas and a better understanding of the physiologic things that do contribute to that. And so again, welcome any questions, comments, feedback, anything we can do to make this better for you.
I do have one, doctor. Hold on just a second. So the question was, what would be your suggested TXA dose pre-hospitally? Was 2 grams one time good for pre-hospital, or do you have a different suggestion?
Nope, that seems to be the trend and the direction that everyone is going in. The initial studies were done on the 1 gram early, and then a 2nd gram over the subsequent 8 hours. But I think most protocols are starting to go to the 2 grams right up front, and you don't have to worry about that. Administering that 2nd gram over 8 hours, and that's what we're doing in the hospital. So if they don't receive it pre-hospital, we're just giving 2 grams up front. Is that? I'm guessing if your protocols aren't calling for that yet, I would bet that they will probably within the next 12 to 18 months when, the next time it's up for review, because that definitely seems to be the trend.
Yeah, we just changed our protocol from 1 to 2 this year. Another question. Adverse reactions to TXA. What might they be?
We're not really seeing any allergic reactions or anything like that, but there is some concern whether or not it does increase the risk of thromboembolic complications, so DVTs and PEs. I think early on there was a greater concern with that, but I think over time we've also gotten more aggressive in hospital at administering, Lovenox and the DVT prophylaxis earlier in traumatic injury. And I think that significantly mitigates some of the risk associated with the TXA. So really, that's probably the biggest risk is maybe an uptick in blood clots. But that is a mitigate. That's tomorrow's problem. That is a post-injury day 2 and 3 problem and beyond. And we have ways to mitigate that with earlier administration of anti-clotting medicines and things like that.
I don't see any others in the room. I don't see any online, so I think we are there. Thank you. Thank you, everyone. Thank you, Dr. Beldowizc, for your presentation. Oh, hold on.
Thank you guys. Appreciate you.
I think I see a hand raised. Sorry, somebody did raise their hand online.
Okay.
I don't know if you can see that under questions on your end. So it's given the pH challenge shown in the beginning of the presentation, could you see replacing NS and LR with carrying plasma light or fluid resuscitation in the future?
So interestingly, they did I just read a study that did show that it was associated with an improvement in mortality in hospital patients, not in pre-hospital. But its biggest problem really is the expense. It's significantly more expensive than LR and normal saline, and the benefit is probably seen only in a small minority of patients, right? So I don't know that it's going to become the standard, but again, I think it just goes to show that fluid is not always helpful, right? Like it dilutes the coagulation factors. It does significantly exacerbate acidosis. And the truth is, like, LR is designed that, in a normal physiologic patient, when you administer LR, the liver metabolizes the lactate, and the end effect is actually pH neutral on the body. But in a patient who's in hemorrhagic shock, their livers they're not functioning normally. They're already generating tons and tons of lactate, more than the liver can metabolize. So those are patients that are not necessarily going to behave. They're not going to neutralize that acid in the LR the way a normal patient would. But I guess I can't say that for sure that it's going to become the standard pre-hospital, because our standard fluid here is still, when we give it, it's usually still LR. And I think that's just kind of where the standard is right now.
Okay, any other questions? One more. Go ahead, Tanner. They are in many agencies. So the question was EMS protocols for blood products. And I know there are multiple systems in the country that do carry blood products, and I think as Dr. Beldowizc said, it's usually in the metro areas, more likely to use it. Blood's not going to get wasted, and you got to have a short travel time to get the blood there to them quickly. Dr. Beldowizc, anything else you would say about that?
Yeah, no, I mean, I was part of a working group that was talking about those specific problems, and the problems are still very prevalent. Everything from there is no way really for EMS to bill for it. Again, there is that idea of wasting that product of once you put it out in the field, it still has to be temperature controlled until it's administered. It needs to go through, so in order to preserve it, it needs to be cold. But then, to administer it, you got to run it through a warmer, and so there's the expense of the blood plus the expense of the warmer. So there's a lot of logistical things, but there is a lot of very smart people paying attention to it. That because more and more data is coming out that is showing substantial improvements in mortality. So in addition to the study that I showed, there's two studies. One is coming out of San Antonio, Texas, and another one coming out of New Orleans that both show, that they instituted a pre-hospital blood program and showed significantly lower mortality in patients that received blood pre-hospital. And so I think more and more cities, I think ultimately it's going to need to be sort of government sponsored or funded, and in some way that that makes it. I don't want to say profitable, but like, I mean, if an ambulance company or is going to invest in the infrastructure to store blood, to preserve it, to infuse it with warmers and things like that, there has to be a way for somebody's going to have to help with that stand-up cost, and whether that's going to be city governments, county or state, or even federal, somebody's going to have to help that. But I promise you, there are some very, very smart people who are committed to troubleshooting those sorts of things. And like I said, it's going to be rolled out in Multnomah County. I think it's just been, just the last couple of years that it's Life Flight is carrying it now. So that's definitely the direction things are moving in.
Okay, this time we're really going to call it good this time. Thank you. Thank you, everyone.
All right, appreciate you guys.